everybody, this is Dr. Pruett. Today we're going to talk about a very important and relevant topic of bleeding control. This is something we should all be experts in, and I'm excited to talk about it today. We all know that it's very important. Bleeding is one of the major causes of pre-hospital death in the field, and it's very preventable. So today, hopefully after our talk, you'll be very comfortable addressing it and dealing with it. What makes this topic so pertinent is that, unfortunately, there are increasing active shooter events each year where this is becoming not so much of a military wartime problem as a civilian problem as well. Here's a look at mass casualty incidents, and this is data from 2015. I'm sure the incidents have increased over the last 4 years as well. The important point to take away here is that 35% of pre-hospital deaths are a result of hemorrhage, and this is a very preventable thing in general. There is a national campaign called Stop the Bleed that is endorsed by the American College of Surgeons and also a National Committee on Trauma. I'm proud to brag about our program here in the city where we're doing something called lifesaver training, and hopefully by the end of 2019 or the middle of 2020, we'll have every employee in the city trained in how to stop the bleed, and not only that, but how to apply and use an AED and administer Narcan as well. So as these problems are moving closer and closer to home, we are developing very creative strategies to deal with them and save lives here in our city. 54% of active shooter events have occurred in workplaces or academic settings. So when we're done training city employees, we're looking to expand the Lifesaver program to different workplaces and also academic centers or schools to make sure that civilians are prepared for these unfortunate emergencies. And if you start to look around at airports or some public places, next to the AEDs that are on walls, you'll start to see Stop the Bleed kits. I know we have them in our airport, and they're stocked with some trauma gauze, some gloves and eye shields, as well as a couple of tourniquets. So look around at the places you're in and see what resources you have available, and ask yourself, if there was to be an emergency here, where would you find your emergency equipment? So one of the things that makes bleeding control so important is that people can bleed to death very quickly. I was surprised to learn that you can bleed to death from a femoral artery injury within 3 minutes. That happens very quickly, and again, it emphasizes the point that it's important for lay people to be prepared to stop bleeding, because there's no way that EMS can get to the scene in time to save these lives, but bystanders absolutely can. So I know I've been emphasizing that there's 5 places to bleed to death. Just quickly try to review in your head while I go over them. One of the most common is the street. These are extremity hemorrhages that we have control over. You can lose a large amount of blood into a leg or a femur. A pelvic fracture, abdominal trauma, and chest injuries can also cause life-threatening bleeding. If you think about it, most of our major vessels are covered with bones or fatty tissue or muscle that protect the arteries that are vital to our survival. The arms and the legs, though, are most vulnerable to injury, and this is where our extremity hemorrhages occur. We've got the subclavian artery that comes off the aorta into the arm and makes the brachial artery and divides into the radial and ulnar arteries. Then in the leg, the aorta bifurcates into the iliac arteries, goes down into the femoral artery, and then feeds the foot through the anterior tibial and posterior tibial arteries. There's lots of ways that bleeding injuries can occur. One of our most common here in the city is penetrating injury, whether that's knives or guns. Injuries to vessels can also be caused by blasts or crushing injuries. Another common place where we'll see this might be a car wreck or a motorcycle wreck. And a very important one not to forget about is bleeding dialysis fistulas. If we think about a very common scenario here in the city, say we've got a rollover MVC with a trapped patient, you're able to access the patient but can't get the patient out. So you approach the scene when it's safe and you notice that the ABCs are intact. You get a set of vitals with a blood pressure of 150/60, heart rate of 120, O2 sat of 98 with a GCS of 15. But as you look a little bit closer, you see an open tib fib fracture that's bleeding pretty briskly, and you know this is going to be a prolonged extrication. I want you to think about your management strategies here. When we're talking about initial assessment of bleeding patients, I know we've all been taught the ABCs before, but what we're learning over the last 20 years while we've been at war is that there's something a little bit better than ABCs when dealing with trauma patients, and this is the MARCH acronym. And this is learned from tactical combat casualty care. First, and most importantly, in a trauma patient, we want to control massive external hemorrhage. Then we address the airway and the respirations and the circulation. There's 4 ways to do this, and the easy way to remember it is the 4 Ds of massive hemorrhage. The first thing you want to do is detect. So it's very important to expose these patients and find all the places that they are bleeding. Then you want to apply direct pressure. 80% of bleeding can be controlled with direct pressure and doesn't necessarily need a tourniquet. Now, if this wound is pretty severe and is requiring all of your concentration, and it's only you as a single provider, then in that case, a tourniquet might be an option so you can move on to address your other priorities. But remember that direct pressure is a very important key to stopping bleeding. Like I mentioned, you can move to devices if you need to. Usually in our cases, that'll be a tourniquet. And as you're moving on down your algorithm in terms of patient treatment, it's important to get IV access and help treat hypotension, but remembering that we don't want to increase the blood pressure too much. So with our fluid resuscitation, we're going to have a goal of what we call permissive hypotension and titrate that fluid to a systolic blood pressure of 90. So on my initial assessment, what I like to do with trauma patients is assess the level of consciousness and the skin color and their peripheral pulses. Now, it's important to note here that none of these things require any fancy equipment. You can usually tell this pretty quickly by looking at the patient and touching the patient and quickly feeling for a radial pulse. Now, why this is important is because you don't want to get behind the 8 ball in terms of hemorrhagic shock. I know we've all seen this table before, and it's a little overwhelming. I'm terrible at numbers, and this is a lot to memorize. It's a lot of fodder for test questions. What I want you to take away here is if you look at the class 3 shock right here, this is a patient who's lost almost 2 liters of blood, and the average adult patient has 5 liters of blood in their system. So you're looking at a patient who's lost just about half of their blood volume. And the thing I want you to realize here is that if you have a trauma patient with a pulse that's between 120 and 140, and they're anxious and confused, and they're breathing fast, you can safely assume that this is a patient that's in class 3 shock. And what this tells you is that they're bleeding to death somewhere, and you need to address it quickly and get them loaded and go to a hospital. Blood pressure doesn't matter so much, but I want you to realize if you've got a tachycardic patient with a significant trauma mechanism, you need to load and go because this is a seriously ill patient. One of the easiest ways to tell how sick they are is whether or not there's a radial pulse. If you have an absent or thready radial pulse with a tachycardic and tachypnic patient, you need to move. Just some more evidence supporting the fact that these patients can be pretty sick. If you have a patient that's bleeding in an extremity that you can control, 96% of these patients were saved if a tourniquet was applied before they were in shock. But if you wait until it's too late to try to control a hemorrhage, there's only 18% survival. That's a massive difference in mortality with these patients. So early control of hemorrhage is key. Now, I don't know if you all have heard of the triangle of death before, but it's something fairly commonly referenced among trauma surgeons and emergency medicine doctors, and it's an important concept to emphasize here. If you think about it, the basic definition of shock is inadequate tissue perfusion, right? And what that means is that the tissues are not getting enough blood. And when tissues don't get enough blood, they tend to find an alternate mechanism to stay alive, and that goes into anaerobic metabolism, which builds up a lot of lactate, which is an acid. So as there's less and less oxygen delivery to the tissues, your patient is going to develop an acidosis. And what this acidosis does is a couple of things. One, it cuts off blood flow to the less important tissues in order to perfuse the more important heart and lungs and brain. So the periphery is going to get hypothermic. And not only that, but the acid, as it changes, it's going to change the conformation of the proteins in your body and make it harder and harder for the blood to clot and stop bleeding. So as the patient gets more acidemic, because of the lack of oxygen delivery, they're going to get more prone to bleeding because their platelets and other clotting factors are not working correctly. And then they're going to get more cold. And as the patient gets more cold, the patient's going to get more acidotic, and the coldness is also going to affect the ability of the clotting factor. So it's this endless circle that just gets worse and worse and worse. Now, the two things that we can correct in this triangle of death are keeping our trauma patients warm and trying to prevent tissue ischemia by, one, stopping all the bleeding that we can, and two, permissive hypotension, giving them some fluids to replace a little bit of that volume, and three, getting them to the hospital quickly. Now, it is important to consider that a lot of bleeding can be controlled by direct pressure, and not all bleeding needs a tourniquet. Common questions that you might ask yourself or ask others are tourniquets a last resort? And the answer is absolutely not. If you see pulsatile bleeding, put that thing on quickly and get that bleeding under control, because as we learned earlier, massive hemorrhage can happen very quickly. In the past, there used to be a big fear of applying tourniquets because that meant that the limb would be lost. And that is not necessarily true. More and more evidence is coming out that tourniquets are safe and can save lives. It is important to consider, though, that commercial tourniquets are much better designed and give better control than improvised tourniquet. If an improvised tourniquet is all that you have, then by all means use that to stop bleeding. But if you have a commercial one available, it's highly recommended to use that. We all know that you need to think about a tourniquet anytime there's uncontrolled extremity hemorrhage, whether that's an amputation or a mangled extremity or a penetrating injury. Pulsatile bleeding that you can't control with direct pressure is a wound that needs a tourniquet. You really want to get control of that hemorrhage early. Benefits of tourniquets: if we go back to our rollover scenario, you can address a life threat very quickly, especially in a limited manpower scenario. That's going to take one thing off your plate to control bleeding for you. They can save lives. They're very quick and easy to apply, and they can make a big difference for your patient. Now, they aren't without risks. Ischemic tissue injury is the big risk. Sometimes nerve damage is a consideration. Acute renal failure, compartment syndrome, blood clots, and necrosis are all things that could happen, but happen very rarely. If we look at some data from the American College of Surgeons in 2014, they absolutely recommended the use of pre-hospital tourniquets with significant extremity hemorrhage if direct pressure isn't working. So don't be afraid to use tourniquets in the pre-hospital setting. They did recommend that these were commercially produced windlass tourniquets. They distribute the pressure over the right amount of area over the artery and do a great job at occluding arterial flow with limiting tissue damage from the underlying skin where the tourniquet's applied. If we look at more literature from pre-hospital emergency care in 2015, this is from a Boston EMS experience, and they also concluded that early EMS tourniquet use was safe for extremity hemorrhage in the civilian setting, not just a wartime setting, and had infrequent complications. If we look a little bit closer at their data, 98 tourniquets were applied in Boston over the course of this time period. 50% of those were placed by BLS providers. So this is important, not just for ALS, but really BLS or even lay people to realize that this is a life-saving measure that's right at our fingertips. And with all of these tourniquets applied in Boston, there were no deaths or amputations due to tourniquet use. Only one possible minor nerve injury was reported. Again, in the Journal of Trauma and Acute Care Surgery in 2015, this was looking at some data from Los Angeles with civilian use of tourniquets, and again, there was low rates of complications, high potential for benefit, and they recommended aggressive use of this potentially life-saving intervention. In LA, the median tourniquet time was 75 minutes, and there were no complications noted for about 87 patients. And then more data from the University of Texas with a retrospective study, again confirming no complications due to tourniquet use in patients up to age 91. So important things to know about tourniquet use in the civilian and in the pre-hospital setting is that the standard for leaving them on is 2 hours. This is very well supported by the literature that there's really minimal risk for ischemic injury. Really what the literature is showing is that you can leave them on for up to 6 hours. What that means for us in the city is don't be afraid to use them, because we're absolutely going to get these patients to the hospital in time to get them off safely and try to save that limb. Now, importantly, when you're placing tourniquets, you want to put it directly on exposed skin. So you want your patients to be trauma naked, get those pants off, get the shirt off so you can get access to those junctional areas where the arteries are closest to the skin. And you're going to use that long bone to tamponade the artery against the long bone using the tourniquet. So you want to get the pants off, get the shirt off, find all the holes, and then get that tourniquet in the right position. You want to apply it as high and tight as you can above the wound. Use that long bone to your advantage, and the closer you can get to the core of the body is where that artery is going to be easier to occlude. You never ever want to put a tourniquet over a joint. You want to make sure you tighten it until you can't feel a distal pulse. And make sure you note the time of application. If you need to, you can always put a second one on, especially on legs. If you have a male with large quadricep muscles, sometimes it can take 2, and that's okay. Mistakes that people commonly make when using tourniquets are not using one when they should, or waiting too long to determine whether or not it's life-threatening hemorrhage. Don't be afraid to use a second one if you need to, and be sure to make it tight, knowing that this is going to hurt, but you're saving that person's life. You can address the pain later. And don't ever take it off prior to definitive care. And the one exception here would be, as civilians tend to use tourniquets more and more, if they put a tourniquet on a wound that you think is pretty clearly not an arterial bleed, it would be okay in the pre-hospital setting to loosen it and evaluate that wound and evaluate the bleed. Tighten it if you need to and they were correct in placing it, or take it off if they were incorrect in placing it. I'll leave that up to your clinical decision making. It is important to realize that tourniquets are very painful, and you're going to be making that limb ischemic on top of some underlying tissue damage and likely fractures as well. That doesn't mean that you did it wrong. Don't take it off if you already assessed that they need it. You can treat the pain with narcotics or other modalities that we have available. Now, there are some injuries that are too close to the body's core to be amenable to tourniquet use. So if someone is bleeding in their neck or their armpit or their groin, what do we do? So there are hemostatic dressings that are available, but don't forget that you also have direct pressure. You can just use your fingertips. So anytime you're using these hemostatic dressings, whether it's fancy gauze that has embedded clotting factors in it or just the simple 4x4 that we have, your fingers are the most valuable things that you have with these junctional injuries. So you don't have to pile gauze on top of each other. What you want to do is just use your fingers, find the vessel that's bleeding, and occlude it the best you can. If you do decide that gauze is your best option, you want to expose the bleeding like always. You want to locate exactly where it's coming from and pack that gauze tightly over the vessel that's bleeding. Make sure you're leaving your fingers there and you're using at least 3 minutes of direct pressure. Sometimes more will be needed if you have an arterial bleed. You can use more gauze if you need to, but realize that making 6 more inches of gauze over the skin is going to just diffuse that direct pressure over a larger area and not necessarily occlude the vessel that you're aiming for. So some more literature is emerging about junctional dressings. Hemostatic dressings are effective, and if you're unable to use a tourniquet, it's okay to use wound packing as second line. One important point I wanted to make about bleeding is with fractures. It's easy to think about broken bones and feel like they happen in isolation, but when you look at an anatomical drawing of a leg, you see the bone here, but look what's next to this bone. All kinds of vessels and nerves. And so when this bone breaks, it essentially turns into a knife with super sharp edges, and it can cause a lot of vascular and nerve injury as well. And every time that leg is flopping around as you're transporting that patient, just think about it as a knife that's just cutting back and forth on all that other tissue that you can't see. So it's really important to stabilize these fractures. One, it's going to provide the patient more pain control because that fracture isn't flopping around, but it's also going to be better for your neurovascular status as well. You always want to make sure anytime you have any kind of fracture to document a pulse and movement sensation before and after you splint. But realize that when patients have broken bones, they also have underlying tissue damage as well. This is important to think about with pelvic fractures. Open book pelvis fractures is usually a anterior-posterior kind of compressive force to the pelvis, and then there's vertical shear, which happens a little bit more commonly in car wreck victims where one leg might be posteriorly forced where the other one is not. Either way, both of these kind of fractures can cause very significant bleeding into the pelvis. This is one of the 5 areas where patients can bleed to death. Usually this bleeding is venous and can be easily controlled by just placing a pelvic binder. I don't think that we do this enough in our system. And if you have a patient that's in hemorrhagic shock, I want you to remember that this is one of the places that you can help control the hemorrhage and help stop the bleeding. When you do apply these, it's important to realize that they're going to be placed lower than you think. So the part of the pelvis that you can feel, the iliac spine up here, you actually want to go lower over where the pubic symphysis is. And the technical name for this is you want to place it over the greater trochanters of the hips, where the leg rolls in and out. And this is what's actually going to close that open book and pull that pelvis back together. So just reviewing the 5 places that we can bleed to death. We know we can bleed to death from extremities, and I sometimes refer to this as a street. We can control that easily with either direct pressure or tourniquets. The femur obviously has large vessels there. We can control that with splinting and direct pressure. Pelvis, we just talked about the pelvic binder. Now, if you have a patient where you suspect bleeding in the chest or the abdomen, these are the big questions that we really can't control in the pre-hospital setting, right? But if we look beyond the horizon at what might be coming over the next couple of years, there's something called Tranexamic Acid, which is a fairly cheap medication that's been used in the third world for a long time to control postpartum hemorrhage in ladies that give birth and have significant bleeding after the birth. Basically what this does is it's a medication that helps stabilize clot formation and helps stop bleeding. Right now it's looking promising in the pre-hospital setting, but I just don't feel like there's enough literature or support for its use here in the city when I'd really like us to just focus on getting these bleeding patients to the hospital. But some studies have shown improved survival by 70% if this medication is given immediately after significant trauma. And in rural settings and in third world settings, there's definitely been a survival benefit shown that for every 15 minutes in treatment delay, you can increase mortality by not giving this drug. The big question anytime you stop bleeding is if you're going to cause clots. And clots can be just as deadly as bleeding can. And so we're still waiting for more evidence that this is effective for urban settings. Another way to control massive hemorrhage, we talked about one of the 5 places is the abdomen or the chest where patients might bleed to death. This is a surgical procedure called the REBOA that physicians can do and insert a line into the femoral artery that basically has a balloon and can cut off blood flow to the legs and make sure the blood flow just keeps perfusing the abdomen and the chest and the head. They're doing this in Great Britain already because they have physicians in the field that can do this on scene and have had pretty promising results. Another emerging thing that's becoming popular among trauma surgeons and has been well researched in the wartime combat setting is whole blood. What we're finding is that if you transfuse whole blood, it's easier and more effective than giving platelets separate from cryoprecipitate, separate from FFP, and separate from red blood cells. If you give it all together all at once, it's less packing and it's more effective. And I think it won't be long until the UNM trauma surgeons at the hospital will be giving this. It's a little difficult to think about giving it in the pre-hospital setting because there's many logistics involved right now. But it's something that's on the horizon and it is important for you to know about. Really what I want you to take away from this talk today is that hemorrhage control can absolutely save lives and we need to do it early. Direct pressure is going to work 80% of the time. Don't be afraid to use your tourniquets and know how to use them. And talk to your family and friends about how to use them as well. And that's all I have for you. If you have any questions, please contact your 7-8. Thanks.